Hello and welcome to the Farm Reform Podcast. I'm your host, Jonah Comstock. I'm editor-in-chief of Farm Reform, and I'm joined today by Eloise McLennan, deep dive editor at Farm Reform. We're going to do something a little bit different today. We're not talking about an event we've been to, although we may mention some events we've been to. We're talking about a hot topic in this space, the topic that we constantly see by our own internal metrics that readers are excited to engage with, and that is GLP-1s. The new treatment initially for diabetes and obesity, now increasingly for all kinds of conditions, that has really taken the pharmaceutical world by storm over the last 2 or 3 years. We're going to talk about as many different aspects of the GLP-1 phenomenon as we can fit into 30 minutes, from the cultural to the scientific to the economic. So very excited to dive in and see where this conversation takes us. Eloise, welcome to the show.
Hello, thank you for having me.
So, let's kind of start. How have we're both journalists. We cover the pharma space. How did this sort of like first start to cross your radar? When did you first start to realize that we were dealing with sort of an epoch-defining drug here in GLP-1s?
Oh, well, I think anything that begins with a Gila monster is going to grab my attention. So I started really seeing this maybe 2, 3 years ago, but I had heard rumblings about it just from friends that I knew who went to UCL, which is University College London. I knew that there was some research into how GLP-1s could be used in Parkinson's disease. I don't believe that actually went anywhere. I think they struggled to get the funding for the placebo. But there were some rumblings back then. Didn't think it would apply to my life, but it really does now. And yeah, definitely over the last 2, 3 years, despite the fact that Jonah was studying the Gila monster in 1990. And I believe the first was it Extendin 4 was approved in 2005. It's not a new phenomenon that we've seen. I think what we've seen the real rise in is the use in obesity. So I think the use in diabetes and the use in Parkinson's and possibly Alzheimer's to an extent was much more of a prospect over the last decade. But really, in the last few years, I think optically, when you start seeing celebrities talking about Ozempic or denying Ozempic, that's really when it starts to become sort of that cultural phenomenon that you can't escape. What I've been particularly interested in recently is that stage beyond the initial prescription, because there is a lot of focus on getting people onto GLP-1s, but not necessarily the same interest in that endpoint, that end goal of, okay, when can we start to titrate? When can we start talking about adherence? Because adherence rates aren't great. But yeah, Gila monster and that intersection of a cultural phenomenon and a pharmacological phenomenon. Very
Yeah.
interesting dynamic. Very rare dynamic, I think.
Well, I think, yeah, because obesity is so widespread, and the number of people who could potentially benefit from these drugs is so huge. And then there's a understandability to it too. I mean, people might not know what a glucagon like peptide is, but people know what a miracle weight loss drug is. We've heard that term used in sort of sketchy ways applied to all kinds of things for years and years, but this is, pretty much
Mhm.
actually one.
We are still hearing it now. It's not a miracle weight loss drug. I would like to be very clear about that. It is very effective in what it can do, but it is not the silver bullet. It requires external changes as well. If you stop taking it in 3 months' time because you think you've lost enough, you've lost the 3 pounds you were trying to lose, you have made no lifestyle changes, you have made no other changes apart from going on the drug, you are very likely to gain that weight back. So it's not a miracle weight loss drug. It is a prescription drug in the same way that any other prescription drug is effective, I suppose.
Yeah. Yeah, absolutely. I mean, and it, what I think it's done that's been really interesting, and it's starting to do, and this is something I talked about in my recent panel at Bio, is it's starting to have some effect on the stigma and the way that we as a society think about obesity and weight loss, and shifting that narrative from this idea that it's a lifestyle disease, that it's somehow the people who deal with it are at fault, to really treating it like a medical condition, like we treat other medical conditions. So
Oh, for
it's
sure.
important that we consider it in that context, but that by itself, I would argue, is sort of a game changing thing, right?
Um, Absolutely, for sure. In terms of, and I would add this to diabetes as well, and to an extent, Parkinson's and Alzheimer's, is that they are very emotive conditions. In that diabetes, you are going to have to change everything in your life essentially to ensure that your insulin levels are where they need to be. It is a huge impact on your lifestyle. Obesity is a huge impact on your quality of life. Parkinson's, any neurodegenerative disease is going to impact your life. So I think that emotive quality alongside the stigma and the shame that comes hand in hand with both diabetes and obesity, it is a very, as I say, uh, emotionally impactful subject. And so
Yeah.
to have a drug that seems to offer a solution to that in a way that treatments that we have prescribed before, the way that we know that people speak about the disease, the way that the industry professionals have spoken about the disease in the past, it is, I can understand absolutely why it is seen as a miracle in that instance. However, to me, I think the miracle drug phenomenon is less about um, destigmatizing obesity and diabetes, and more about the sheer number of indications that this drug or this drug class seems to have an impact on. And that I think is a really interesting thing to look at as we move forward, in that it's not just a one and done with diabetes and obesity, but again, neurodegenerative disease, musculoskeletal disorders. We're looking at particular cancers, at heart conditions. These are really serious conditions, and as seemingly effective class of drugs that could bridge those gaps. So that, for me, is where the miracle drug side of things comes in. But I think for an emotional standpoint, absolutely anything that is going to help you change that is phenomenal, in my opinion.
Yeah, one thing that came up a lot in this panel is just this notion that, basically there are two hormones that we've started to apply this kind of uh, approach to, right? The GLP-1 itself and
Mhm.
GIP. But there are way more hormones that could potentially be effective if we block them in the way that we block GLP-1s. And so, like, this is really, it's not just one new kind of drug, it's a whole new kind of paradigm with a lot of like room to explore, because all these hormones interact with each other, they interact with the brain, and we don't really fully understand that landscape at all. We're still learning how it works. We don't even completely understand why GLP-1s, one receptor antagonists, have the effect that they have on weight.
Never question the Gila monster. The Gila monster knows. Absolutely. But if we look at like musculoskeletal, the quality of bone depends on bone metabolism, and we've seen that GLP-1R is present in bone marrow stem cells. osteoblasts, osteocytes, and osteoclasts. And so looking at whether or not GLP-1 RAs have the potential to impact those cells. As you say, so many different hormones, different proteins seem to react and respond to this class of drugs. And I think another one is the fact that it can cross the blood brain barrier, which has always been a tricky one for any new drug development, is how you can cross that barrier. And I think that's a particularly interesting uh, ability of this class.
Do you want to go through kind of some of the areas of emerging promise for this beyond sort of?
Could you tell? Could you tell that I wanted to look at that? Absolutely. So we've mentioned a couple of them. We've mentioned musculoskeletal, neurodegenerative, um, quite promising research coming out in terms of Parkinson's disease and Alzheimer's disease. What else can we talk about? Addiction. This is an interesting one. This is one that I was not expecting at all. So musculoskeletal, anything to do with a degenerative disorder, when you're looking at sort of protein building, and basically where we were looking at GLP-1s, I could understand Alzheimer's, Parkinson's, cardiovascular, particularly if you're looking at obesity, any reduce in weight or any weight loss is going to reduce the risk of heart conditions. But it was addiction that really came out of left field for me in terms of the ability to reduce both recurrent alcohol consumption and overall alcohol intake in rats, I believe by more than 50%. Specifically, alcohol-dependent rats who were given semaglutide. Now, if you don't know, semaglutide would be your Ozempics, whereas there are other forms of GLP-1. So you've got, say, I'm going to mispronounce this badly. So tirzepatide, which is sort of the Zepbound that you're looking at. I can never. I have to brace myself to say these names every single time because they don't come off of my tongue. But it was semaglutide, particularly Ozempic, which is the lowest dose that they could have been given. That was a very interesting one, and I'd be very interested to see how that progresses from here. Because again, it's another very emotional. It's a disease. We know addiction is a disease. It's another very sensitive topic. It comes with a lot of stigma. It is an area where we're seeing some real strength with GLP-1s. It's going to be really interesting to see how that continues from now.
So we're really blazing through our half hour. So I want to talk a little bit about the patient side here. In particular, what's been happening with the compounding, with the gray market, the access issues. I mean, there's a whole really, I'd say, kind of concerning trend going on there.
Absolutely, and I've wrote about this last year in terms of when there was medication shortages, and I spoke to someone from Novo Nordisk when I was at Health earlier this year, Health Europe to be specific, and I asked her, how does a relatively small pharma company prepare to be one of the biggest names in healthcare? And she said, we had no idea. We knew our drug could do something special, but nothing could have prepared us for the amount of demand that we were going to have to satisfy. And that does come from off-label prescribing. It comes from there was an awful lot of illegal activity that went on there. With you would see a lot of websites popping up with research-only labels on their medication bottles or on the injection pens, or you'd see very clear diabetes pens that had been tampered with, and that became a real issue, not only because nothing had been prescribed for weight loss at that point, that it was off-label prescribing that was meaning that patients with diabetes could not get their medication. Now, that was a real issue. And then on top of that, not only do you have the risk of you don't know what is coming in the mail to you, you have no idea where that comes from. It, again, coming back to, it is a prescription medication, which meant that you had no idea of the quality. You had no idea of the levels that were in each dose. So you had no idea if your dosage was the same every single time. And that consistency means something. It is very important. And then you had the rise of the bad actor hydras, which is, I get them all. I made the mistake of one time researching a GLP-1 story and not turning my incognito mode on. And now I get an influx of weight loss medication adverts, one after another. And the Advertising Standing Agency in the UK has really tried to clamp down on this. You now can't even show a weight loss injection pen or a diabetes injection pen. You can't show anything that looks remotely like a medication, and you have to be very careful with wording. But when you say things like medicated weight loss or those sort of words, it implies that you can just go to that service and immediately get access to these drugs. And that definitely shouldn't be the case. It should be with somebody who knows your case, who is familiar with your health, and not a case of filling out a very obvious survey that then gets you access to a medication. Because ultimately, you don't want to potentially spend dollars, pounds, thousands on a drug that, because you were not given the same level of management, of interaction, and of guidance, that drug then, when you come off of it, and we'll talk about this in a moment, because while it is a very, very effective drug, it does come with side effects, and patients may not be willing to endure those side effects, come off of it quite quickly, and then they see the results that they had wanted fade away. That's not the ideal solution. We want patients to see a longer term effect. But we need, as I said in the beginning, those external factors that surround and support the drug also in place to help support those patients. Because talking about efficacy rates, I think last year, was it the NIH published a paper that said that overall GLP-1 persistence was at 46.3%. I just want to make sure I get my notes right. At 180 days, and 32.3% a year. The highest rates were for semaglutide, and the lowest were for liraglutide. That is a problem. And it's something that we need to address, is once the patient is on the medication, how we can then support them on their way through. And I think that's something that pharma companies are beginning to address. That's
I
my...
want to talk about adherence, but I want to talk a little bit about the gray market first. This is something we discussed a ton at this panel, and it was really useful to have like a patient on the panel in Michael Donnelly Boylan, and Michael said something really I thought powerful, which is, people are doing all sorts of crazy things because you basically had a desert this entire time, and then you threw the ability to get water from a lake into it, and then you told people they can't have it. The whole situation got much worse when the shortage was declared, and the compounding pharmacies all sort of started to make these drugs as fast as they could. And then they were told that the shortage was over and there's no more compounding. You created, in some ways, it feels like the government, the U.S. government, by declaring and then ending that shortage, sort of created this gray market. I mean, you couldn't have done it better on purpose.
Oh, I don't know if I would agree with that, because compounding pharmacies are legal during times of shortage. I'd say that it was the sort of celebrity demand that pushed that. If you can see rich and famous people getting access to a drug that you are being told you can't have, that I do believe creates the imbalance, and it's the optics of it. Because we have social media, we have the internet now, you can, in a way that I don't think you could really put on similar drugs that had that same cultural and pharmacological clash. you can see when people are getting medications in the same state that you are being told that you cannot get. Um, and these people definitely opt, at least from the outside, uh, would not be people that you would necessarily put into the category of being of needing a GLP-1 drug.
So the question becomes, what constitutes a shortage of a drug that, like something like 1 in 3 people in the population could potentially benefit from, right?
Again, had not been at that point approved for weight loss. Uh, and I think that was a big issue, is that it was being prescribed off label so much.
Yeah.
And that's what created the shortage. Because if it had just been diabetes patients, number of diabetes patients, yes, it's high. It's not that high. And as I was saying, when I spoke to the representative from Novo Nordisk, she's like, no one could have seen that level of demand coming. When we talked about the tariffs, we've talked about how long it can take for manufacturing plants, for facilities, delivery, for all of that supply chain system to be put in place to deliver that demand. The real issue, I think, with that grey market was there were a lot of people taking advantage of people who, as we talked about, very emotional, very emotive conditions, wanted access and were being given subpar products, if the correct product at all. Um, and that, I think, is where the big issue came through. I completely understand patients seeking out different routes, especially if they're being told that it's because they're not trying hard enough. And then visually you see how effective the drug can be. I can completely understand that. But I don't think it can just be placed at the government's doorstep and said, oh, it's because you allowed compounding that we had this big issue. I think when it comes to this sort of drug, it also is a societal and cultural factor as well. I think that's the big one. And again, you have to take a step back and remember that at the time, Ozempic, it was a diabetes drug, but it was known as the weight loss drug, even
Right.
though it was not approved.
The hype and the marketing got so far ahead of sort of the science and the official designations because it was such a
Exactly.
powerful drug. Is
It still is.
and
And
so
it's very,
thinking about
sorry,
adherence, I think one of the issues there is that it is an injectable that has to be given.
not all of them these days.
Well, that's what I wanted to talk about. I wanted to talk about the oral formulations because those aren't um, there. There's one oral formulation that is approved for diabetes. There isn't
Yes.
one yet for weight loss, but there's
No.
several that are in the race. Um, and there seems to be kind of an assumption that the oral form will have better adherence and it'll be easier for people to remember to take a pill. But we haven't necessarily seen that with the one that's been approved in diabetes. At least it hasn't. It didn't immediately grab all the market share away from the injectable version of the same drug. So I tend to wonder if it's a more of an open question than people want to consider, whether an oral formulation is really going to make that big difference. But I'm interested to hear what you think.
I would wonder if that is due to what you're familiar with. If you are familiar with using an injectable, then you're likely to stick with an injectable because it is part of your routine. I'd say it's easier to forget to take a tablet than it is to stab yourself with a needle every day. Uh, and I do think it becomes part of people's routines. Um, in terms of weight loss, I think that's a bigger deciding factor, is that may be easier to become part of people's daily routines, because unless I'm mistaken, I know a few people, myself, who are on GLP-1s, who have to go into the clinic to have their injections. That is an imposition. It is very
Yeah,
infuriating to do.
but
Diabetics can self-administer at home. So it's that ease of use, I think, is a big one, and familiarity.
medication
If you
adherence is a challenge in almost every condition for which medications exist, right? But
It
Um,
is.
and one of the reasons for that is the classic problem of when you start to feel better, when the symptoms start to go away, then people almost have just these very short memories where like, oh, I'm cured, I don't need to take the pill. I mean, that's a classic problem in psychiatric medication. And so I
It
wonder,
is huge.
when we look at the adherence for these GLP-1s, and even with the injection, what have you, like they lose a bunch of weight and then they stop taking it because the weight is no longer an everyday, you know, thing in their life reminding them that, hey, I need to be, doing something about this, right? Like,
Yes, and I think that is a big issue that we're going to have to look at. And I think one of the ways I spoke to the CCO from Weight Watchers about this is they have pivoted towards GLP-1 drugs. They are looking at how they can utilize their community basis, their community foundation of having these small groups go together who are motivating each other, talking to each other. Because if you're going home and having quite severe or noticeable gastrointestinal side effects, you're less likely to continue taking it, particularly if you consider it to be optional. And I think that is a big problem at the moment, is that weight loss is considered optional in a way that if you were taking a statin, that's not necessarily optimal. It's not. Maybe I'll take my statin today. I'm not really sure. Uh, it's that area of it, and it's why I come back to saying that it is a prescription medication for a reason. It is incredibly powerful, but you still need to have that support network around you. And I think that's somewhere where Weight Watchers may be able to have somewhat of an advantage over a drug company alone, because they have those units already in place.
and maybe that can be kind of the last thing we talk about, because we're coming up at the end of our time, is how should these drugs interact with the existing weight loss ecosystem? It, and I'll start on this one because this was an interesting thing we talked about on the panel. And there were a couple of analogies drawn, and one of them, Dr. Beverly Chang, she drew the analogy to like glasses. Like, if you go in to the eye doctor and they say, oh, you're straining your eyes, you're probably spending too much time looking at screens, you're probably sitting too close to your computer, those things may be true. There may be lifestyle reasons for your poor vision, but your eye doctor is not going to say, is not going to send you home and say, I'll give you some glasses after you work on sitting further away from your screen. They're going to give you the glasses first, and then hopefully you won't have to sit so close to the screen. um the idea is that, like, there's a lot of kind of stigma in obesity that maybe the medication should be the last resort. And the idea that was kind of put forward on this panel was maybe it should actually be the first step, because then it enables you to treat your condition in these other ways. And another analogy that was drawn was to like psychiatric medication. If someone comes in who is like massively depressed, you don't necessarily start with talk therapy and say, oh, we're going to prescribe an antidepressant as a last resort. You give them the antidepressant so that they can get into a mental space where they're actually able to develop skills to cope with their depression. And then when Dr. Chang sort of described this, Michael, who I talked about earlier, the patient, said, that's exactly how it happened for me. Like, once I had the Mounjaro, the inflammation went down and I was actually able to walk for more than 15 minutes a day. And so an exercise routine like became possible. So I thought that was just really interesting idea that, like, let's turn around how we're thinking about this. But yeah, what are your thoughts? How should, as these drugs become more commonplace, hopefully for the people who need them, like, how should we think about the whole treatment paradigm in weight loss?
See, I'm sort of halfway between those two schools of thoughts. The eyeglasses analogy doesn't work for me, because in my head, do you want to prescribe something that is going to be harsh on the body if it's something that can be at least begun outside of a pharmacological intervention? Eyeglasses, you're not going to be able to fix your vision on your own. you need that intervention. With weight loss, I think you can get the ball rolling. And I think, coming back to what I've said multiple times throughout this, is that there needs to be that external change alongside the internal change, in order for it to be long term. In the same way that we've treated gastric bypass surgery, that you have to reach a certain target weight before we do this, because we need to make sure that you're taking this seriously. And I'm not saying that patients are not taking it seriously, but taking those first few steps, this is where I think it is really important that you are working with a prescribing team that knows you. And if you have inflammation, then they can assess the inflammation. Are you going to actually be able to increase your exercise, or is that an unrealistic expectation? It's where I worry more about those online services, that you don't necessarily see that person in face to face. You'll give them your BMI, they'll take whatever they need, and then you just get your prescriptions. Is that you need that intervention from the team to assess what your goals are. And I think the big thing that patients themselves as well need to take into the meetings with their clinicians is to talk about, okay, what is the end goal, and how are we going to approach getting me off of the drug? So that, I think, is a really important conversation for patients, is what am I using this for, and what happens afterwards? And I completely understand the idea that patients wouldn't want it to be a last resort,
For some
but
patients, I
you
don't
want
think
it
there
to
is an
be
afterwards, right? I mean, it's a chronic condition. Someone else said on the panel,
exactly,
chronic conditions require chronic treatments. Maybe some patients do need
absolutely.
to be on this drug for the rest of their lives.
And if they don't, but again, that is something that should be worked out with their prescribing teams, and it should be done on a case by case basis. We always talk about how patients are not monoliths; they are not one big individual. They should be treated as the individuals that they are. Um, my point really is that it should be on a case by case basis, with both teams working together. Because again, it's not a miracle drug; it will do what it does, but you also need to make some changes to see those results last over time. Because the thing we want ultimately is for your health to be improved long term. Whether you're on the drug for a really long time, if you're on it for a few months, we want to see your health improve. We want to see it help improve if you do come off the drug, if you don't come off the drug. That's the real thing. And there needs to be a structure in place to begin to work that out beyond prescription. So we need to look at that beyond prescription stage more closely, I think.
Well, I think we have reached the end of our self-imposed deadline for the timing on this podcast. I know there's much more we could talk about, and perhaps we'll do a part 2 one of these days. But thank you
I
so
could
much
talk
for
about this
joining
for
me.
hours.
Any final thoughts?
No, I think it's going to be really interesting to see how the market changes over the next few years, now that there are a few more competitors that are becoming as known as the Ozempics and the Zepbounds, Wegovys of the world. That one's going to be particularly interesting, and again, just to see the other iterations that these drugs are being approved for. That's going to be particularly interesting, and navigating the regulations.
Yeah, something we didn't really get a chance to talk about.
Part two.
Yeah, exactly. Well, just trying to think if there's anything we want to plug. I know I've got a couple pieces I'm working on right now on GLP-1s. Hopefully they'll be coming out around the same time, and we can put them in the show notes. But we've also done some great reporting already. Eloise in particular has written some good stories about the gray market that we talked about. So check it out on Pharma Forum, and thanks for listening. That concludes another episode of the Farmer Forum podcast. You can find more information about this episode, including a download link and information about previous installments, at farmerforum.com/podcast. The Farmer Forum podcast is also available on Apple Podcasts, Spotify, Overcast, Pocket Casts, Podbean, and pretty much wherever else you download your podcasts. Just search for Farmer Forum and follow and hit subscribe. Of course, don't forget to visit the website itself, where you can sign up for daily and weekly news and analysis bulletins, and follow us on Blue Sky and LinkedIn at Farmer Forum. That's PharmaPhorum. That's all for now. Thanks for listening.